two and a half years. Earlier, Dr. Harita used to report with me. Now Ketan is reporting, and the concept of this, the implication of this was started 3 4 years back, where we developed the software. That time, Dr. Deepasri was there with me. So all of us together we have started this concept of reporting MIC guiding table and therapeutic index uh, to the patient report. So now Ketan will tell you what is therapeutic index and how it is going to improve the clinical decision making on antibiotic selection. Over to you, Ketan.
Uh, so, let's first we see that what are the various ways which we can through which we can deliver our susceptibility report to the clinical team. Let's start with the very basic one. So we can go with reporting with only raw MIC values. I have seen reports released in various settings, very small settings, that they mention only the MIC values along with the antibiotic places. This is the worst kind of report that can go for a clinician, for a patient. Then we can report with only interpretations included. We have a list of antibiotics with the interpretation as susceptible, intermediate, or resistant. This is little better because a clinician can see for the S and choose among the antibiotic, but still a so inferior kind of report. The next level of report where we report raw MIC values, we include raw MIC values extra in the report along with the following interpretation. This helps to some extent the clinicians, especially working in high risk or critical care areas, because using the MIC they get in some idea, but actual scenario it gets them confused. Because what's the, if you release these kind of report, the usual concept by the clinician is, if it's 1, if it's 8, if it's 4, if it's 2, always go for 1. This is a usual concept. So as far as delivering the report, it's fine. But as far as the confusing the clinician and promoting their wrong decision towards choosing the antibiotic, this is not a correct way. What are the other ways? We can go that we'll report the raw MIC values along with the clinical breakpoint range. This is how biochemistry reports are now there. You give a value along with a range. So similarly, AST report can also be released in the same way that you release with MIC value. We are giving our interpretation along with the breakpoints, and the clinician may be instructed that we take this breakpoint to decide whether it is susceptible or resistant. But it depends very variously, it varied completely based on the understanding of the clinician, whether he'll properly understand the breakpoints and whether how it is varying from there, how the interpretation was. Clinical decision making in this kind of report is again complicated. So here comes the new concept that which would solve this problem. How to choose the best antibiotic? Suppose my organism, my isolate is susceptible to a series of antimicrobial agents. In those cases, the concept of MIC therapeutic index is very helpful. So, because as I've already told you, clinicians often tend to go for the value of MIC. They saw a low value and they grab that. So, but this is a wrong concept, because MICs are in vitro data, and in vivo it is not. It may not be effective as such directly. So in those cases, what is important is the actual effectiveness depends on the number of folds the MIC value is below our the susceptible breakpoint provided to us by CLSI, UCAST, or any such governing bodies. The actual effectiveness is depending on that. Based on that, the concept of MIC therapeutic index, which is also referred to as breakpoint to MIC quotient, yani BMQ. So it can be termed by both the names, breakpoint to MIC quotient or MIC therapeutic index. It must be brought in your mind that this therapeutic index is completely different and at all not related to the drug therapeutic index. Okay, that's why it's better to use the term MIC therapeutic index than to use the term directly therapeutic index. So it should be clear that it is therapeutic index related to the MIC of susceptibility. So how we calculate MIC therapeutic index? It is calculated as the susceptible clinical breakpoint of that particular drug bug combination as provided to us by CLSI, UCAST or any such body. We divide it with the actual MIC what we get on susceptibility testing. I again tell, for intermediate, we usually don't calculate MIC therapeutic index. For resistant isolates, you don't calculate therapeutic index. We calculate therapeutic index for sensitive or susceptible isolates only, because these are which are going to be used for therapeutic purposes, with an exception that for colistin, because it is no intermediate, no susceptible breakpoints are available, you can still calculate a therapeutic index based on its intermediate profile. So let's go with an example. The earlier examples what I've already quoted. Suppose a scenario where a bloodstream infection, you have got Klebsiella pneumoniae, you got a series of antibiotics, cefepime, Magnex, Piptaz, and amikacin. You have reported MIC values, the interpretations, and the breakpoints. So let's see for cefepime, the MIC what I've got is 1. The breakpoint says that a breakpoint of 2 or less than that would be my susceptible strain. So anybody can unmute and tell me how to calculate this MIC therapeutic index based on the above discussions we have.
2 divided by 1. 2, sir.
2 divided 1, that we get a
Should be 2.
Similarly, we can get for others also. What's in this case? What's the MIC?
4.
4, yes. Similarly, for amikacin, it is going to be 16 divided,
8.
that is 8. Yes.
8.
So our report, we should calculate it, and our report should also display it. We should preferably display it along with our report. The therapeutic index should be included in the report. You can include the breakpoints or you can skip the breakpoint, is our option. But the MIC values, the interpretation, and the therapeutic index must be included in the report. And the clinicians should be taught that higher therapeutic index value means the drug is comparatively expected to be more efficacious, applying certain rules, which are we going to discuss now. So
It has to be done routinely.
Yes, ma'am.
Is this to be done routinely?
Yes, ma'am. It should be included routinely in your daily report, including
Even if we are doing manual testing, AST?
That is what I'm going to discuss. This is yeah, even if it's you're doing a MIC based detection method, the limitation it can be may not be applied for a disk diffusion testing. Even if you're doing a manual testing by broth microdilution or agar dilution method, MIC based and E strip also. So any MIC based test, you have to do this.
Right. Thank you.
Now, this was therapeutic index, MIC therapeutic index. Now, the concept of MIC guiding table. Sometimes understanding the MIC therapeutic index, when we mention it as a value 1, 2, 4, 8, it is difficult. It becomes exceptionally simple when you include a therapeutic index along with MIC guiding table. I'll say you should plot something like this. So how you have to do? You have to, all the antibiotics, you have to enlist what you are testing for. You have to make susceptible breakpoint, intermediate breakpoint, and resistant breakpoints. Mention all the susceptible breakpoints mentioned in CLSI, UCAST, FDA, whatever you are using. Then you plot the dilutions you are using. If you're doing a manual method, mention all the dilutions. If you're using a Vitek or any other automated system, then whatever dilution is provided by that system, you should plot it on either directions. And then the actual MIC, you should in the report, this is also should be given in the report. You should encircle it. So how it is easy for the clinician to understand, you should tell a simple line that the farther it is from the yellow line, the better the drug is. This need not calculate the value 1, 2, 4, 16. No, you see the boxes, black boxes, how far it is from the yellow line. This is the only instruction you have to tell to your clinician. The box is farther away from the line and it is going to be susceptible. How we created it, it's very simple. In the previous example, what we have already discussed, The breakpoint was 16, our value was 2. The breakpoint was 2, our value was 1. Similarly, we plotted it. It's very simple. But for understanding, for the clinician's purpose, MIC gradient table is excellent. But there are some limitations, rules for it. The rules we'll discuss. So one rule we should apply is it should always be released with the concept of cascade reporting. So what is the concept of cascade reporting? We already discussed that it's selective reporting. The higher broad spectrum drugs, the more costlier drugs, the report should be released only if the earlier ones or the narrow spectrum ones or the less costly oral ones are not susceptible. For preparing, you can take help from WHO aware classification. For preparing, you can get some idea from the CLSI, ABCO categories, but it should not be copy pasted from these category. It should always be modified and prepared by each institute for their institute. It cannot be used for, it cannot be prepared for one institute and copy pasted in another institute. And for preparing it, as sir has clearly told, it's not the microbiology people who to decide, it is the pharma people, it is the clinical team. What drugs are available actually in your pharmacy, what drugs your clinicians usually use and don't use. So those preferences should always be included while preparing the first line, second line, and third line. So we use our clinical microbiology knowledge of antibiograms, we mix the clinician's choice and pharmacy available, and then we decide. So likewise, in our JIPMER, we have formulated a group of antibiotics in the first line. We color coded for easy understanding of the clinicians. We have color coded it. So all the first lines we color coded as black. Similarly, we color coded the second line antibiotic groups as green, and the restricted the third lines should be color coded as red. We include MIC value, interpretation, and therapeutic index. This is a snapshot of our report, which we routinely generate for all the patients. So we included MIC value, interpretation, and therapeutic index for the patients. And but even if this report is available, it should not be thrown to the clinician as this report is we are seeing on this screen, because we can see we have a series of first line drugs coming susceptible. So when we get a series of susceptible, at least two drugs or one drug, a good drug susceptible in the first range, we should not give the old data. So what we'll do is we'll do the cascade reporting and we'll give only the first line drugs to the clinician. Let's do a quick revision. Suppose this is the YTech report we get from our YTech or MIC testing. So this we categorize as per our rule in for my institute as first line, second line, and restricted lines. My first lines are all resistant. As I've already told, if it's resistant or intermediate, we don't calculate MIC therapeutic index. It's not applicable. Remaining, we have already discussed, but can be someone mute? So we have a for Magnex, we have a MIC therapeutic index of 6.
Anybody can unmute and answer.
One.
Tazobactam will be the drug of choice.
Okay, we'll go slow. We'll directly won't jump to the drug of choice. So
16 by 16, 1.
Yes.
1, 4, 2, 2.
2.
Then
Acha. 2 again.
2, 1, 4.
4.
right, very right. So this is how we should calculate. Let's go to the next stage of reporting. Suppose I have got an E. coli from bloodstream infection from the blood sample. E. coli is growing. So we have the same report. Now, as my first lines are all resistant, my clinician asked me, I wanted to start between Magnex and Meropenem. So this was my report. So I knew that the therapeutic index of Magnex is coming 1.
1.
Meropenem is coming 2. The concept is higher the therapeutic index, better the efficacy of the drug. So what should be my drug of choice? Anybody can unmute and want to tell us?
Cephaloperazone sulfate.
Why?
Meropenem.
Meropenem.
Why you want Meropenem? Why you want Magnet?
Higher the therapeutic
Magnex.
Higher therapeutic index.
Exactly. So confusion remains whether Magnex to choose or Meropenem. So as I've already told you, the rule of and therapeutic index cannot be bluntly applied everywhere. So it's always the included with our AMSP goal, which has part as cascade reporting. So you cannot report higher generation, broader spectrum antibiotics and encourage their use. So as we have
So
correctly
second line first.
second line, first
Please
look at anything susceptible in the
Yes.
first-
compare within one category,
Yes, it should be
Yeah.
the same class.
Yes.
same class of drugs, right?
So the first filter is cascade filter. Second filter is therapeutic index.
So here we can see that
Got it.
this can vary for your institute. So this is an arbitrary situation where for this particular institute we have kept magnex, piptas, etc. as a second line drug, and meropenem, carbapenems, etc. usually is a higher gen for than a BLB like combination. So we take it as a restrictor third line. So these categorization may vary for your particular users, institute, ICUs and all. But if a second line is available, even if it is a low therapeutic index than your higher ones, you still choose a lower one. So we have a first line resistant, second line TI of 1, third line TI of 2, but still we choose 2. So drug of choice is Magnex in this case. A second scenario we'll select. Suppose I want to choose between Magnex, Piptas and Cefepime in this case. My clinician wants to ask whether I can choose among Magnex, Piptas and Cefepime, what to be chosen. So I know my therapeutic index values. Can we suggest the drug of choice now?
Piptas.
Piperacillin
tazobactam.
Yes.
Piperacillin tazobactam.
Yes. So now we among these three, because they are all belonging to the same line, we'll go for the highest therapeutic index. So the line filter must be considered first, followed by therapeutic index concept. Okay. This is one aspect of when directly you should not jump for the therapeutic index. Similarly, a situation, my all first lines are resistant, my all second line are resistant. My clinician wants to know whether I should go for meropenem, imipenem, or tigecycline. What should be considered? Going with the therapeutic index, they have a therapeutic index of 2, 1, and 4 respectively.
Tigecycline.
Meropenem.
Meropenem.
Tigecycline can't be used for bloodstream infections.
Yes, slightly.
Reserved drug.
So even in the same line, you should not also jump directly for the higher therapeutic index. There are certain rules to be applied. Like it is not a blood effective antibiotic. It doesn't apply certain blood infection. Also to the site specific infections. Not only blood, any site where the drug is going to be effective or not. If not,
Sound is not clear.
So your voice is breaking.
Voice is breaking. Audio.
That is because lot of background noise.
someone
Background noise has to be mute. Will do mute all. Can you do mute all, please?
now it's clear, I guess.
Yeah. It is clear.
Yes, sir.
Yes.
So because it's a blood sim infection, so we cannot abruptly choose tigecycline and report tigecycline. We must, that's why you can't rely upon your clinician to choose a drug of choice. You cannot let them choose based on a therapeutic index. After a therapeutic index, after a MIC guiding table, there should always include a comment which should mention drug of choice is this. If suppose you have specific more things to apply, like if renal parameters fit, you have to use is give renal adjusted dose. You only get amikacin susceptible, rest all are resistant, and it's a CKD patient. You should mention that amikacin is drug of choice in bracket with renal adjusted doses. So your drug of choice comment should always follow a therapeutic AST report, including therapeutic index, MIC guiding table, followed by a comment. So in these cases, you must include a comment that meropenem is the drug of choice. Okay.
And one more comment is tigecycline can be avoided in bloodstream infections.
Okay. Until unless you are desperate to use those in combination therapy. Suppose you get an XDR where nothing is susceptible, even if it is not, because the reason is it requires poor concentration in CSF. It is more tissue distributed. It has a high volume of distribution. So cannot be given as a monotherapy. If you are very forced to do that, then we can do in combination therapies. Let's give an example. We have an E. coli patient presented with a UTI. We have this Vitek report, which we have organized and prepared a guiding table.
Let them answer.
Can you any of you mute and analyze it and tell me what should be the drug of choice? What should I pick? So I'm sorry, it's not categorized as first line, second line, but still.
Amikacin.
Amikacin.
Yes.
Amikacin.
So usually, as our last category was, so piptas, magnex, amikacin, they are usually kept as so one class we have to keep in first line, and second, and same from the another class we can keep is in the second line. This is what the rule says. Same class, different antibiotics should be split. So amoxiclav we can keep it as first line, we can keep piptas, magnex as second line. Similarly, gentamicin you can include in first class, amikacin you can include in second line, discussing with your clinicians. So in this case, we have amikacin, which is belonged into second, and it is also effective in UTI cases. So correctly, it was amikacin. What about, this is a case of Staph aureus in a soft tissue infection. And so this is the report which is given to you. So what should be the drug of choice? Can we analyze and unmute and let me know? So we have oxacillin tested, levofloxacin, cotrimoxazole, tetracycline. Then we have
Rifloxazole.
Why not consider the oxacillin?
Floxacillin can be used.
So it is a dicey situation. First, we should look is the line. So we have 4 antibiotics available in the first line, correct? Among the first, we have 3 antibiotics which are susceptible. Among these, the therapeutic index wise, these 2 have the higher therapeutic index. Then we look for the patient profile, which antibiotic fits better. So it's an SSTI case, we can treat it with either of the 2. For tetracycline, we can use doxycycline, which is for clinical uses, and also cotrimoxazole can be recommended. So your drug of choice would be, in this case, cotrimoxazole / doxycycline can be used for therapeutic index. Okay. Same scenario, suppose you get an MRSA, exact same scenario, you get an MRSA in a SSTI. So then what would be your decide? It's an MRSA. We know anti-MRSA drugs is vancomycin, linezolid, daptomycin, dalfopristin, quinupristin, ceftobiprole. What would be your take on this, considering the susceptibility profile?
Vancomycin.
Anyone else?
We will work on MRSA.
Cotrimoxazole.
Linezolid.
Very good therapeutic index.
Therapeutic index wise, rifampicin has an excellent therapeutic index.
Rifampicin is reserved drug.
Yes, it is
Yes,
reserved.
reserved drug.
Excellent.
Going for vancomycin, first thing is, if anything is susceptible in my first line or not, whether, then this would be the first filter. The line filter should always be the first filter. Then we see if its adequate therapeutic index is there or not. And I should look for the patient clinical profile. What is the clinical profile? So it says skin and soft tissue infection. It doesn't mean that every MRSA needs to be treated with a glycopeptide. If it's a MRSA, which is a skin soft tissue infection, drugs of other modality than cell wall acting agents can also be used. So if it's a bloodstream infection, yes, definitely you will be a little cautious on using cotrimoxazole and doxycycline. But because it's so you can very easily use, even if it's a case of MRSA. Golden rule of that MRSA needs to be treated with MRSA agent. Okay, it can be treated based on the okay lesson in this. And don't just go for blindly go for therapeutic index. That is not how therapeutic index table is used. Always include a comment of drug of choice after the end of the table mentioning that even in this case cotrimoxazole and or doxycycline can be used. Otherwise, it's 100% your clinician would either go out for vancomycin or maybe teicoplanin or something like that. Okay. So what are the parameters?
Dr. Ketan, I have one small doubt, Dr. Suchitra.
Yes,
See,
ma'am.
in the YTech, you get truncated MIC, no, you don't get the exact MIC. How do you go about that?
Yes, ma'am. This would be limitation. We'll be discussing about the limitations. I'll be telling you just.
Yeah. Then I have another doubt. Regarding the first time, you were asking about the blood isolate in case of E. coli. This one, what is that? Choosing between Magnex and Meropenem. Okay. Don't you think, it depends also on the clinical condition of the patient? Because if you are only going by the antibiotic at times, Meropenem may be a better choice to, stabilize the patient. What is your take on this?
No. Meropenem and Magnex both are beta-lactam antibiotics. The mechanism of action is exactly similar. Mechanism of action of all beta-lactam.
Because we have to think about the PKPD also, na?
PKPD
So,
parameters are not available. No, why to presume? If it is available, then it's fine.
No. My doubt here is because, see, whenever there is sepsis, we have to consider the source of infection, right?
Yes, ma'am. Those things are important, but mechanism of action wise, even for penicillin, the lowest beta-lactam, that is penicillin, highest beta-lactam of meropenem, both of them, the mechanism of action wise, it is exactly similar. So if it is susceptible, then always de-escalate to the lowest possible drug possible.
My we should not
Thank you.
these things, and always the best way to discuss with your clinician that
No, clinicians are always biased. They will tell that my patient is unstable, my patient is sick, so I want to go with higher drug. Unstable and sick patient going with the higher drug. This concept is applicable for empirical therapy, but this concept is not applicable for targeted therapy. Targeted therapy, we have an organism, we have antibiotics which are susceptible. Among them, the lowest possible antibiotic, which is after seeing the safety point of view and considering therapeutic index into consideration. So this is the principle what has to be followed. Clinician, we have to convince them that just because you want to sleep well at home, just because you decrease your anxiety, you cannot dump the patient with a disturbed antibiotic.
phone में earphone देखते हो
The others, we cannot hear
we can Nikhil.
Yeah, Nikhil, please unmute. No,
Neeraj,
Neeraj, please.
unmute others.
I don't know why you are not doing the appropriate thing on time.
Sir, if I will mute them, they cannot unmute them.
That is fine. When the background noise is there, you have to nullify the background noise.
Dr. Riddhi, will you please mute yourself?
Okay, so what are the parameters we use to choose antibiotic? We have already discussed this in list. First is our antibiotic line, what we have decided for our institute. Then we should go for the TI filter. We should consider parallelly other factors like how's the renal parameters, how's the patient safety profile, the PKPD profile of our drug, whether it is going to be effective in that site of infection, age profile of the patients, whether if you can give in a pediatric population or elderly, what is the site specific infections, and what are the other culture reports. If you are going to treat a UTI along with a bloodstream infection with two different or same antibiotic with suppose it is having Klebsiella, it is having Pseudomonas or something else, we should choose a common drug which is having the best therapeutic index. You cannot give one good drug from therapeutic index from Klebsiella and Pseudomonas. If we have a common drug, among the common drugs, we have to look for the therapeutic index concept and then decide of our antibiotic. So it has some limitations like the antibiotic dilutions usually, especially in automated susceptibility systems, they have a limited dilution like this example. So the ceftriaxone and ciprofloxacin, the last dilution to be tested in the susceptibility range is our susceptible breakpoint. So the therapeutic index of ceftriaxone cannot go beyond 1. Similarly, for ciprofloxacin, so it would appear falsely as a poorly effective drug. So this may not be the case. Okay, so you should keep these parameters also into the
But
consideration.
405 this problem is not there.
In subsequent panels, like in 405 and 406, they are going to increase the dilutions further. So these limiting susceptible dilutions problem is going to be little sorted out. Same, it cannot be used for disk diffusion testing. The same other parameters must be considered. Site specific infections must be considered. Okay, then polymicrobial infections from the same site or different site, you should always choose a common drug. Reduce the number of antibiotics fed to the patient. You should give, if possible, a monotherapy of antibiotic for 2 or 3 infections if some such drug is available, which can cover all the 3 site specific infections. So in those cases, we have to little modulate with our TI concept. And same thing. So regarding this, we have a concept of ideal, near ideal culture report. So you should mention these things. So it's not about our knowledge. Okay.
No, we will take this ideal culture report also. We are going to discuss subsequently. So therapeutic index and MIC caring table is what we have discussed now. So the summary is therapeutic index is one of the factor to be considered while you select the best antibiotic. At the same time, it should not be the only factor. As Suchitra ma'am told that there are few other factors also which are important. Those also like a specific antibiotic, site specific antibiotic, polymicrobial infections. So all those things to be considered in parallel when you choose an antibiotic. Okay, so but at the same time you should not the clinician should not choose a higher spectrum antibiotic just because the patient is sick, because even if the patient is sick, if you have a organism isolated and an antibiotic available to which it is susceptible, it will always work. Okay, and all beta lactam, the mechanism of action is same. So it is I mean the clinicians are usually getting biased that higher spectrum are better. Higher spectrum will cover more, higher spectrum are better for empirical therapy. But when it comes to definitive therapy, higher spectrum has no additional benefit. For staphylococcus aureus, we all know that cloxacillin is a much superior antibiotic than vancomycin for MSCC isolate, because cloxacillin is a beta lactam. The mechanism of action of beta lactam is much superior. It is a much superior cell wall acting agent. Much sidal effect than vancomycin. So this is all you are going to keep in mind. So now we have 2 more sessions. Like ideal culture report, I will take. Before that, we will discuss how to use various comments in writing the microbiology report. So ideal culture report, I will